Okay, and we are ready to move on to our second topic for today, second or subsequent treatment-free remission attempts. Our international expert for this topic is Dr. Dennis Kim from the University of Toronto and Princess Margaret Cancer Centre in Toronto, Canada. Dennis is a giant in the CML field, and like David, Dennis is back in this forum by popular demand, having made such a great impression when he was an expert in our 2023 ELN laboratory recommendations discussion last year. Welcome back, Dennis. Such a pleasure to have you here again. And finally, I'm delighted to welcome Dr. Katia Pagnano from Campinas in Brazil. Katia is another leading physician and researcher, also in the steering committee for these Latin American discussions, and has always been a great friend of the foundation. On a more personal level, I had the great pleasure of climbing for a cure with Katia in 2023 in Nepal, and she really is great company with a fantastic sense of humor. And importantly, along with me and a host of international CML experts, Katia is backing up for another climb for a cure, this time in Ecuador in February and March 2026. So if any of you out there in the audience are interested in joining us for a great adventure, as well as raising international awareness and fundraising for CML, please get in touch with me. We'd love to have you along. Welcome, Katia.
Thank you,
So I
Arlene,
will take my slides down and Katia, ask you to get your slides up. And whilst you're doing that, I'll let the audience know that we'll run this session a little bit differently from the first one. Katia will present both of her slides side by side to give a compare and contrast between them. But we will have a pause again in the middle of her presentation for questions and comments. Again, to the audience, please don't be shy. Please bring your questions and comments forward to us. Use the chat function or raise your hand and we will ask you. Katia, you are ready to go. Thank you.
Thank you, Arlene, for the kind introduction. Hello, everybody. Now our topic is about the second TFR, second or other TFR. Okay. We have already discussed that TFR is now an important goal on CML treatment, and we know that feasibility, safety, and benefits in quality of life and cost in CML treatment are true and have been demonstrated by several clinical trials. We have several guidelines helping the physicians to stop treatment and to guide TFR in clinical practice, like the Latin America guidelines, European Leukemia Net, and also Brazil and many countries have done the guidelines for that. But we still do not have any consensus regarding second or subsequent TFR attempts. So I will try to discuss this with Dennis. I think the first experience in TFR was done by the French group, and they now have a long follow-up from the first TFR attempt with a success of 44% of the patients in 15 years. And the TFR2 in this population, they had 31 patients, and the longest TFR2 is 9 years now, but they had 17% of late relapse. You see that it's only the difference between TFR1 and TFR2 in their experience is small. It's 39%. We will see that in other works, it's not like this. It's a little this curve is a little bit worse. And they found no advantage using second generation TKI in doing the second stop. This work here is done by Dennis Kim group. So it is the TREAD trial that we had mentioned before. So they did the TFR in patients that was receiving imatinib, and they gave dasatinib after TFR1 failure. So 59 patients lost molecular response after imatinib discontinuation in TFR1, and 55 were treated with dasatinib. So 89% of those patients regained the second MR4.5 or deeper responses, and they were able to discontinue treatment in 35 patients for the second TFR attempt. However, they had 75% of relapse, that patients that lost major molecular response, and 17% lost MR4. And in this experience, they found that there were some factors related with the second TFR. One is the doubling time that Dennis has already mentioned. That's important in terms of success of the TFR. The rapid regaining of molecular response following dasatinib therapy, and undetectable BCR-ABL prior to TFR2 attempt. This other study that I'd like to share with you is the desktop trial. This study was conducted, they included patients that participated in the EUROSKI trial and outside the EUROSKI trial too. Those patients had relapsed, and they were included in the study at least 1 year after the molecular relapse. So they did a consolidation of dasatinib for 2 years. After this consolidation with dasatinib, the patients who achieved MR4, they were allowed to stop treatment after 3 years of TKI after the first relapse, but have to stay in at least MR4 for after 2 years with dasatinib, 1 year of MR4. So this patient was eligible to stop treatment, and in the follow-up, the relapse was patients who lost major molecular response. So this is the curves of this second TFR. We see that it's less than 50%, it's around 40%. The great difference was they found was the duration of the first TFR. So it impacted in the success of the second TFR. You see here in red that the patients who relapsed after 6 months in the first TFR, they had more chance, the curves better, than those patients that relapsed in less than 6 months in the first TFR attempt. So I'm going to show now 2 cases, the real case of 2 patients that I have many things in common. One is a male patient, 42 years old, and another one is a female patient, 54 years old. Both were diagnosed in the same year. Both were low risk SOCO and ELTS. Both have BCR-ABL transcript B3A2, and both started treatment with imatinib, 400 milligrams a day. And they achieved a deep molecular response very quickly in 2013. So these patients really wanted to stop treatment, and then we had a study that we were able to include those patients. This study, it's called EDIPIL. We included patients treated with imatinib for at least 2 years and 2 years in MR4.5. Those patients were treated with imatinib and pioglitazone for 3 months, and then they stopped treatment and went to the discontinuation phase. The trigger for imatinib reintroduction in this trial was loss of MMR or loss of MR4 in 2 samples. So those patients, they enter in this trial. This is the TFR curve that we had of these 31 patients, 60%. But this study was published in 2020. I can tell you that now in 2025, we still did not have any other relapse so far. So the curve is still the same. We had only 3 relapses after 7 months, 1 after 13, 1 after 30 months. And one patient went to blast crisis or lost hematological response. We had something that impact in TFR was the SOCO risk here, low risk versus high risk. And also the duration of imatinib treatment have also impacted. Those patients that were receiving imatinib for more than 9 years, they have more than 8% of success in stopping treatment. But also we had in the multivariate analysis the influence of the MR4.5 duration, as Dennis mentioned before. So those 2 patients, they entered in this trial in July 2016, one in July, other in September, and they stopped treatment. But what happened? They lost very quickly the major molecular response. The patient one lost response within 5 months of interruption, and the other patient lost in the month 3 after imatinib stop. Both patients started again imatinib 400 milligrams, and they had a very quickly recovery to M4 in just 3 months after introduction. So those 2 patients, they really wanted to try a second TFR. So what we did at that time, we let the patients stay 5 years again in treatment with imatinib, this time not less than 5 years. Both, but before I tell you what happened with the patients, I'd like to ask Dennis Kim, in our clinical practice, we encourage patients to try a second TFR attempt. And how long do you wait for the next try? We have discussed a little bit before in Rafa's case, but this will be another discussion to do. And would you like to switch to a more potent TKI to accelerate the second attempt? I think we have talked a little bit about that, but let's open the discussion.
Thank you so much, Katia. That was great. Let's start with Dennis, and then we'll move on to David and Rafa. Dennis.
Thank you. Thank you, Katia. Thank you for sharing this excellent case, which will facilitate our discussion about the second TFR concept. So I will tackle the last question. Should we try switch over to the other more potent TKI to accelerate the second attempt? I think that our Canadian trial was designed to answer that question, whether the switch over to dasatinib could increase the chance of TFR2. So we couldn't find any evidence that the dasatinib use can facilitate the second TFR, to improve the TFR2 chance. So I think that the answer is no. However, what we learned from that Canadian TKI discontinuation trial for the second attempt, what we learned is that the MR4 duration or the TKI duration after failing the first attempt of TFR, that is very, very important. The reason why I'm saying is that when we designed the study at that time, the only dasatinib discontinuation trial was DADI trial, which allowed the consolidation of dasatinib treatment only for 12 months. So we adopt that. So after failing the first TFR attempt, and then if a patient is going to get a dasatinib treatment after achieving the MR4, actually we consolidate them for 12 months based on the DADI data, and we would like to see. However, what happened is that probably 12 months is not enough. 12 months is not enough for not only just for the TFR1, but also for the TFR2. And those patients who failed the TFR1 attempt, they are actually very, very aggressive group of the patient. They are very high risk patient for the TFR failure, which means that they need actually longer TKI treatment duration after failing the first attempt. So it will give you the answer for your second question. So how long should we continue? I think that at least it should be longer than the first TKI treatment duration before you try the first TFR attempt. And now we are now, I think that it's not just the 2 years, maybe 3 years, 4 years, or even longer. And then we have to try the TFR2. And I do have several cases. Even after failing this second attempt of the trial, they are already, out of monitor in the context of the clinical trial. But they retreated with the dasatinib or imatinib, and then now some of them they achieved the TFR3. But they were on a very long period of time of TKI treatment duration after failing the second attempt even. So my answer for your first question, in your clinical practice, do you encourage your patient to try the second attempt? Yes, not only the second attempt, in some patients, they can also achieve third TFR attempt very, very successfully. So that will be my answer for your 3 questions. Thank you.
But Dennis, do you think your magic number is 5 years or Less than
At least 4 or 5 years. Yeah.
At least 4 or 5 years, yeah.
Yeah, but sometimes the
That's my opinion.
patient, they are very difficult to tolerate to that kind of longer duration of TKI treatment. That's why we have to then introduce the concept of a biologically optimal dose. Then we have to reduce the dose, but we will try to increase their total duration of MR4 as much as we can. And then we can try the second attempt or third attempt of TKI discontinuation for TFR.
Perfect.
David, what are your thoughts?
Yeah, I agree with Dennis. Very appropriate comments. I think if you have to say what the preconditions are for a successful second TFR attempt, I think we can just go via our clinical experience at this point in time rather than say this is the hard line in the sand. I mean, as Dennis has said, there are some hints as to what would be what may be the prerequisites for success, but the absolute lines are not clear at the moment. Do I encourage patients to try a second TFR attempt? In many cases, the patients actually encourage me to let them stop a second time. I actually would rather them stay on therapy for a bit longer, but as Dennis has said, you know, this is a two-way conversation between me and the patient, and sometimes their priorities are whether it's toxicity or, you know, trying for pregnancy or the fact that they just don't want to take the tablet. But in those cases, I also offer dose reductions to manage toxicities in what Dennis called the concept, you know, the biologically appropriate dose. But
biologically optimal dose.
Yeah. Now, do I switch to a more potent TKI after somebody fails after they fail one attempt? I think that opportunity is not so common for me because now in Australia, most of the patients that we see now having TFR attempts are patients on second-gen TKIs. But I do build in a discussion, though, when somebody stops and ask them, if you have a molecular recurrence, is this drug that you're currently taking the one that you would like to go back on? Or if you have intolerance, whether we set you up to go on to the next drug, if this is not, if you would rather not have this drug again. And it may be, you know, from imatinib to dasatinib, from dasatinib to lamotrigine, or whatever, depending on the patient's intolerance and their characteristics and their comorbidities. But I do say, though, if a patient stopped a drug and they have no problems with tolerating it, if they have molecular relapse, I would ask them to go back onto the same drug and re-establish a molecular response as quickly as possible.
Thank you, David. We'll invite Rafa to join the discussion. Whilst Rafa comes online, there are a couple of questions in the chat. Lillian from Chile says, what's your opinion about dose reduction or TFR in a patient that has been in DMR 3 years that previously had an ABL1 mutation? And Soledad says, I think it's very important to know the sensibility of MR4, number of control gene copies, and I would feel much more confident to have MR5 undetectable BCR-able before attempting TFR. Rafa, let us know your thoughts to Katia's questions, but perhaps also the question and comment in the chat, please.
Well, our criteria for including patients is mainly those who have more than 5 years of CML, and then more than 1 year in M4 or M5 as a criteria, with a little modification of the European Leukemia Net and also the NCCN. And there are more strictly inclusion criteria for those organizations. But for us, maybe I think in M3 will be so dangerous because the patient has shown in any way some form of resistance to be in M5. It will be for me, it will be risky, and we never include the patients in M3.
Yes, may
Any
have
comment on that?
comment about Soledad comment. Yeah, I agree with you that I feel more comfortable to stop when patient has MR 4.5. Of course, the PCR has to be standardized for you to do that. But when we have the opportunity to compare patients that stops MR4 and MR versus MR 4.5, we had a better, more success in TFR than patients that only in MR4. So I agree with you. And besides the results of the NSTOP trial that included patients that had failed before, I'm not so enthusiastic about stopping patients who were previously resistant. I'd like to hear the opinion of the others about this.
I also agree with Katia and Rafa regarding the not recommending a TFR attempt in the patient having a past history of ABL1 kinase domain mutation development or the progression to advanced disease. In that case, I also do not recommend it because the leukemia clone, their biological behavior, it doesn't change. So I think that if you just stop the TKI pressure, after the releasing that TKI pressure, the leukemia is going to quickly regrow, and then you will see the leukemia relapse. In that case, I think that there's a risk of blastic phase transformation as well. So I'm not going to recommend that. And your MR4, MR5 question of Dr. Soledad, I think that I agree that the chance of TFR is way higher in the patient having an undetectable transcript level. However, the practice experience also tells that those patients just meet the MR4 and just meet the 2 years of MR4 duration with the imatinib. And I initially thought this patient may not be able to, this patient is going to lose TFR so quickly, but I was wrong. This patient now, I think that he came to my clinic last week and he was already now 8 years after stopping the imatinib, and his BCR transcript level is around 4.2, 4.3, 4.2, 4.3 range. So it is still doable in those patients. So if that patient is very motivated for TFR, I'm not going to discourage them. Thank you.
David, your thoughts perhaps on the question and comment and other comments there? You're on mute, David.
Oh, thanks. I just want to clarify what Dennis has said about Lillian's question, which is very sensible. You know, if a patient has already had treatment failure once due to an ABL kinase domain mutation, suboptimal dosing would just encourage outgrowth of more resistant mutations. But I just want to clarify. So Dennis, what about just, so the question was about dose reduction or TFR. Do you think that neither are recommended, or do you think that dose reduction is different to completely stopping drug and seeing what happens?
I think that dose reduction is different in comparison to the complete discontinuation. So this patient does have a little bit of a clonal evolution in terms of ABL1 kinase domain mutation acquisition. And in that case, but the patient already achieved the undetectable transcript level, which means that leukemia clone is under control with current TKI. In that case, you can try dose reduction and to see. However, complete stopping, then you will remove the TKI pressure, then the leukemia clone, which already have gone through a clonal evolution, it is going to come back so quickly. That's my worry.
Right. But you don't think that taking a drug off, even if the BCR-ABL was to come back up again, is more likely to be a wild-type BCR-ABL, given that you no longer are exerting a competitive pressure?
I will still wait this case before we develop some very accurate and reliable biomarker that can predict the TFR success.
Yeah,
I'm a little bit in doubt, whether this case is going to be very successful for that kind of TFR attempt.
yeah, yeah. And as to Soledad's more recent question, the STIM study chose MR4 because they didn't have deeper detection. Now, I don't know if you have the inside knowledge into the working of the LN group, which would have just met at EHA, but I wonder if it is still a problem with the widespread availability of technology such as the caffeine gene expert, whether that is still going to be a limiting factor, technical sensitivity, whether that's still going to be a limiting factor going forward for our TFR studies.
You mean having a sensitivity level of up to like MR5?
Yeah, I just wondered whether the experts in the region has any comments about access to good quality assays with high sensitivity that's reasonably priced for the region, because that would be very critical going forward.
Katia, we might get you to take that on and then move on into the second half of your presentation, please.
Yeah, just I agree, David, that the PCR standardization is critical for doing that, for doing TFR, because and we know that there are many standardized labs in Latin America, but there are also labs that are not so reliable. So it depends on the region you are. But I guess that we are now have more access to kit than we had, for example, 5 years before. Okay, can I go to the second part, Arlene? Yeah? Okay. For the second part, well, as I mentioned, both those two patients, they really wanted to try a second attempt. So now we had another clinical trial that is ongoing. This study it's called this CML, that includes a de-escalation phase before the discontinuation. So this is a multicentric study that we are conducting in Brazil. The criteria for entering the trial is at least 3 years, but we encourage at least 5 years now. MR4.5 for 2 years, typical BCR-ABL transcript, no previous resistance or mutations, and we could include in this trial first or second attempt of discontinuation. So the patients that enter in the trial, they went to a dose reduction phase that lasts 6 months and then stopping TKI. We did a monitoring monthly in the first 6 months, and then every 2 months until 2 years, and then every 3 months. And the trigger for TKI reintroduction was the loss of MMR. So those 2 patients, they entered into this trial. And this is the results that we have so far, 66% in 24 months in therapy-free survival. And then at this moment that we published this first manuscript, we have only in this trial only 42 patients, 4 patients that were trying the second attempt. So those 2 patients, 2 of them are in this trial here. So we have a very different the TFR survival curve between the first and second attempt. So patient 1 and patient 2, they did a dose escalation of this trial. They didn't lose MR4.5 during the de-escalation phase. So they were at 200 imatinib, and they did not lose the MR4.5. So after stopping imatinib, they lost very quickly again, major molecular response. And then they recovered, the patient 1 relapsed. When they stopped the treatment, they were 5 years after he started the TFR, and then they recovered major molecular response 2 months after imatinib reintroduction, 400 milligrams. But patient 2, She has stopped October last year, and now she's still in follow-up. She did not relapse. Remember that the characteristics of those two patients, they were very similar. Since the diagnosis, the risk factors, and they both went to a first TFR attempt, but now one patient relapsed, the other did not relapse. So I would like to discuss with you which factors might impact the second TFR success. Is there any biomarker that is coming that we could differentiate those two patients? Is the immune system? And the patient one, he's now in MR 4.5 again, and he would like to try a third attempt of TFR. But what I did, because he complained about some chronic effects of imatinib, now he is on 300 milligrams imatinib. But he would like to try the third attempt. So what do you do for this patient? Thank you.
So again, we might start with Dennis first, and then David and Rafa.
Yeah, so I think that I shared our trial result a little bit in my previous, the answering the question about yours as well as Rafa's questions. So I think that to me, the most important factor to increase your TFR2 success is the duration duration of the TKI treatment after failing the first attempt. After failing the first attempt, usually they gain the MMR within the 3 months, 3 to 6 months, they will regain MMR. But from that moment, I think that they have to have their MR for duration or MR 4.5 or undetectable or whatever as much as they can. And then it will increase their chance of a second TFR. That is number one. And I do not think that switching the TKI is quite necessary, but who knows, maybe later on, once we have a larger number of the data, that also may impact on their depth of their response. But I do not think that they will be the first factor that will affect the success of the second TFR attempt. So the most important thing is the MR4 duration or deep molecular response duration after achieving the MMR after the second attempt of before you try the second attempt of the TFR discontinuation. And any risk of progression after the second or third attempt, if you are talking about progression to a blastic phase, I think that their risk of progression to blastic phase after the second or third attempt is quite the same, but there's still risk of their molecular loss after the second or third attempt, and I think that you also have to see that what is their kinetics of their molecular loss after the first attempt or after the second attempt. If it seems to be very, very rapid, they already experienced a very rapid loss of their molecular loss. Probably they may have a faster leukemia kinetics than the other cases, and they will require much longer treatment duration than the other patient who has very slow loss of their molecular response. That is my opinion. Thank you.
Thank you.
Rafa, what do you think? Rafa, would you like to join?
Yes.
There we go.
Yes, you can hear me now?
Yes, thank you.
Yeah, I think the emergency of mutations is another factor who may impact in the response, and the patient will, including progress to the blastic phase during the recovery of the treatment, as we have seen in our patients particularly. The 8 to 9 mutation and inclusion of the 35 nucleotide inclusion is we have seen as the most important factor who the patients may not respond to the second attempt.
I did not have any, all the patients that the first TFR attempt, they all recovered responses after reintroduction, in the median time to achieve the major molecular response was 3 months. So unfortunately, I didn't have any patient that has failed to the TKI reintroduction after TFR.
David, what are your thoughts?
I just want to clarify, Katia, because I do agree with Dennis's comments earlier. So there is a difference between patient 1 and patient 2 of total duration of treatment of at least 3 years then, isn't it? I think that may not be the only reason why patient 2 has succeeded and patient 1 failed, but it is that the duration of treatment is longer in patient 2. And I think it speaks to Dennis's previous point that, if patients has had one failed TFR attempt, they may be keen for a second one, but they may need a longer period of treatment to consolidate that response before a successful TFR2 attempt. But the patient 1 is also somebody that I can picture in my practice. So somebody is very keen to get off drug for whatever reason, and they will ask you again and again, Dr. Katia, when can I stop again? Dr. Katia, when can I stop again?
It was like this. I had a bit much work to do him wait 5 years to stop again.
That's right. And I myself would think, look, I would rather you stay on drug a bit longer because I really don't want all that extra work to set you up for another failure. But it is true, coming back to what Soledad said earlier, if they sometimes, these patients, I think majority of patients are actually very, very good, but sometimes I do wonder whether some of my patients have even taken themselves off the occasional dose more than once, and compliance may be a problem. But this is that you can only counsel.
Yeah, I have to admit
that now it's getting so popular to stop treatment that some patients are doing for themselves. I have 1 or 2 patients that had stopped
that's dangerous.
by themselves, and they just come back. I stop treatment.
That's dangerous. Yeah, but yeah.
I think the somewhere in the participants is Dr. Luis Mellon, which is from Mexico City too, and he suggests that we must have a much careful evaluation in these patients who are poor adherence to the treatment. I think it is very important in population like Latin America, I think.
Yes.
Mm-hmm.
Yes, I agree, because sometimes after many, many years of treatment, we start seeing that patients do not go to the pharmacy to take again the pills, and they don't show up. How come? Because they are doing like drug holidays, or they are stopping 1 or 2 or 3 or more days during the month, and then that's a problem. I agree with you, Rafael.
Yeah, I got a call from the pharmacy. They are now asking me whether you have intentionally maybe stopped the treatment or not, because the patient filled the 3 months of Dasatinib January, and he came and he is now asking to get a refill now. So it means that the 3 months of medication, but he didn't take it properly. So I think that it is very, very dangerous to, in terms of that kind of irregular intake, right? Adherence is one of the most important factor for their successful treatment, but sometimes they neglect that. That is the problem.
Mm-hmm.
So I think Rafa might have just taken the question from earlier. Dr. Luis, adherence is always a concern. Are reduced doses more risky for a relapse when adherence is not optimal? We were going to come back to that later, but I think Rafa largely took that question. If not, let's bring that back into the discussion as well. Where were we? Dennis.
I think that is a very, very important topic, adherence, or in other words, we call it tolerability. And adherence is not just from the that kind of behavioral issues. Sometimes because of lots of side effect or toxicity, patient becomes intolerable, and then they just not take the pill in a regular basis. Because of that, I think that in order to improve their tolerability and adherence, we have to think about the dose reduction in some patients if they are maintaining the optimal response. So that's why that is the concept I mentioned about the biologically optimal dose. Biologically optimal dose means that we just use the drug based on phase 1 study, and based on the phase 1 study we determine the RP2D, and we just utilize that RP2D forever. But leukemia, particularly in CML, they have a totally different leukemia kinetics. So before they reach up to MMR, they have a very rapid reduction of their leukemic burden. After that, they go to very, very slow process. So maybe a two different growth curve, and you may not need to utilize the same dose of imatinib that you used to before you achieve MMR. But after achieving the MMR, then you can reduce the dose, but their leukemia may not come back so quickly, and they will maintain the deep molecular response even you reduce the dose of their TKI treatment, which will also help to relieve all that kind of side effect or toxicity, or improve the tolerability. So I think that that is the reason that I'm now utilizing that kind of concept of a biologically optimal dose in my clinical practice in my CML patient. Thank you.
Thank you, Dennis. We'll go back to Katia, but also we'll bring in Mariana's question about gender. Is gender a real risk factor in considering second TFRs? What do you think?
Well, in our experience, it's not so many cases. I have seen different experience. Some people say in some places I have seen papers that gender matters, but in our experience, no, it didn't matter. But in our particular patients, there were 5 TFR second attempts in this trial, and only the female patient is now in TFR. The others have had relapsed.
I think, Arlene.
Yes, Rafa.
I think maybe in gender will be in general not be a prognostic factor,
Yeah.
but I think the only group of patients who are those that are pregnant during the treatment and they have to stop therapy, and they frequently have a very hard to return to remission because they have to stop the therapy during the pregnant period.
I think gender is hard because there are biological differences in drug metabolism. There's differences in absorption. There's difference in adherence. There's difference in immune mechanisms of TFR maintenance. So I think it's very difficult to actually tease out if it is real, and if it's real, what that's due to. But until we actually have clinically relevant guidance, and what I mean is, for instance, if it's a male TFR participant, we would expect different conditions to starting that TFR or stopping drug compared to a female TFR participant. Until we get to that point with some evidence, I think even saying that there is a gender difference may not actually guide our clinical practice so much. So at the moment, there may be, as Katia said, there may be a difference. It's in some studies, it's not in other studies, but we have no evidence to treat our patients differently at this point in time.
Mm-hmm. Perfect.
Dennis, do you treat differently?
Oh, I agree with David. I think that I'm not going to treat differently based on the evidence that we have, although we have that kind of suspicion that gender or sex differences would affect our treatment outcome based on the many reasons. Their hormonal status is different, their genetic status is different, etc., etc. However, right now, based on the currently available data, I'm not going to treat them that much differently. So I think that I agree with David.
back to Katia.
Okay, no, I had already made my comment about this. I agree with them.
So do we have any final comments or questions from our experts or the audience on our second or subsequent TFR attempts?
Second TFR attempt is very, very challenging, but it is doable. And I think that is the reason that we still have to think about it. It is potentially possible. So in our clinical practice, we still have to keep in mind that this patient who just failed the first attempt of TKI discontinuation, they still can consider the second TFR. I think that is the message that we should deliver to our CML practitioners in Latin America. Thank you.
Yes, and wait at least 4 or 5 years to do that, like of MR 4.5 to be more successful in the second attempt.
No disagreements from me.
Any last comment from Rafa? Last comment from Rafa?
No comments about that. I have all my comments that I have done before.
Okay, Katia, I think you have a last slide there.
Yes, I have some acknowledgements to do to the people that work with me in the clinical practice and clinical trials, all the groups that work together, all the CML patients that have participated in the trials, our Brazilian group leukemia. And I would also like to talk to you about the Climb for a Cure 2016. We are going to Ecuador, and any help will be great. If you want to climb with us, if you want to contribute anyway, I'd like to thank you all the participants of this session. Thank you very much, all the people that are watching us too.
Thank you very much, Katia. And with that, we are out of time for this session today. Thank you very much, Dr. Rafael Hurtado Monroy, Dr. Katia Pagnano, Associate Professor David Jung, Dr. Dennis Kim, and our interpreter, Veronica, who will need a big long rest after this. It's a big long session for an interpreter to do. And of course, we'd like to thank you, our audience, for joining us today. I will send links to the recording of this session and some information about the next session, which I think you can see here. Another great lineup of speakers for engaging topics. And do look out for a post-event package that we'll send out to you tomorrow. Please visit our website and the Knowledge Centre. It really is packed with great learning, and feel free to contact me at any time if you need help with any CML matter, as we are very well connected, as you can see. Thank you very much for today.
Thanks for hosting.
Bye.
Thank you. See you. Bye.